Well, welcome to the Anja Health Podcast. Today, I'm super excited to have another OBGYN on our podcast, Dr. Joe Roofeh, who is based in LA and has a focus on robotic surgery. So thanks so much for being here.
Of course, I'm happy to be here.
So how did you get into the field of obstetrics and gynecology, and what in particular made you want to focus on gynecology?
I got into it actually through in med school. Just doing the rotation. I think the first day actually, after seeing my first delivery, I kind of just fell in love with it. Before that, I didn't really know much about the field to begin with. And going through med school, I tried to compare other rotations with that one to see if anything compares. Maybe I want to go a different route, but nothing was even close to it. So I'm like, I got to do this. It was kind of like a calling.
Yeah, that's awesome. Cool. Well, I'd love to know more kind of about your background. I know you mentioned earlier offline that you have a background in Detroit and even in Israel and things like that. I'd love to know more about, just how you got to where you are today.
Yeah, I've been around. I grew up in New York in a small town on Long Island called Great Neck. And then after I went to college in New Orleans, I was at Tulane for 4 years. I got my bachelor's there and went to Israel for medical school. So I was there for 4 years doing my medical school. And then after that, I jumped to Detroit for my residency, where I was there also for 4 years. And while I was in Israel, my family moved to LA from New York. So the next step was, come closer to them and live in LA. And I started working in LA about 3 years ago. I started at Torrance Memorial. I was there with the hospital system for 2 years. And then about a year ago, I decided to start my own practice where I work in LA Century City area. And throughout the years, I got my robotic training in residency, and I just continued, honing my skills on that. And it's something I offer
Cool.
as a way for minimally invasive surgeries.
Yeah. How do you define robotic surgery?
It's just it's a technique used in laparoscopic surgery. It's the same essence as laparoscopic minimally invasive surgery, but there's this Da Vinci device that is used to manipulate the laparoscopic arms. Mm-hmm. So you're kind of just sitting on a console, so you get more dexterity. The tremor isn't as big of an issue, and it allows you to use or get different angles that you normally wouldn't get using laparoscopic surgery.
Okay, cool. So what are the typical use cases for that?
Any minimally invasive surgery, you can use a robotic system. Ovarian cystectomies, you could use them for hysterectomies, for surgeries for endometriosis, if there's a lot of adhesions that you're trying to take down, or if you're trying to do surgery for women who are having trouble with fertility prior to IVF transfer, or prior to them trying to conceive naturally.
Okay, awesome. Cool. Well, I'd love to move into sort of our first segment around cord blood banking specifically, because as you know, we do cord blood banking at Anja Health. So in your eyes as an OBGYN, what are the pros and cons to cord blood banking, and how do you approach it with parents who ask your opinion?
So I'll start with the second question. With parents who ask me about it, I kind of tell them that it can be looked at as kind of like an insurance policy, which is I think the best way to look at it. We take some of the blood from the umbilical cord right after delivery, and we're able to store that for X amount of years. I think it's about 20 years. Mm-hmm. And what I tell them is, hopefully you don't have to use it. But if you do, if you're God forbid your child has some kind of bloodborne illness like a leukemia or any like organ deficiencies, we're able to use that stem cells, because it can regenerate into any type of cells, to be able to kind of treat their ailment. For the first question, for the pros and cons, the pro is it can treat things that weren't treated back in the day before cord blood banking, like childhood leukemias, cerebral palsy, any of those deficiencies. So now we have that opportunity. Other pros, especially with Anja, is we can store the placenta. So that's used for skin grafts, or if children are running around the house and they get a burn from touching the pot, which is pretty common. You can use the placental tissue to graft the skin to make it kind of look like new. And then honestly, the cons would be one, you have to pay for it, which there's a cost, but over a 20-year span, the cost isn't that high. And the other con would be no, if we try and extract some cord blood, if there aren't actually stem cells within the blood, but that's from the literature, that's pretty rare for that to happen.
Yeah, definitely, especially with the rise in stem cell expansion.
Yeah.
Yeah. So do you have any kids yourself?
No, I do not.
Okay. Would you do cord blood banking for your kids?
Yeah, of course, as an insurance policy, always my intent is to never use it, like any kind of insurance, but I would just to have that ease in the back of my mind that there is something that I can do in case my child does have anything like that. Then I do definitely recommend it, and when I do have kids, God willing, I'll do it too.
Okay, awesome. I'm curious what your take is on delayed cord clamping as an OBGYN, and also how you can do it in conjunction with cord blood banking.
I mean, delayed cord clamping in the literature is shown to be beneficial to the baby. I think we can do a combo of both, do some delayed cord clamping, and then, I think the research was 30 seconds to a minute, closer to a minute. And then after that minute, whatever's left over, we can use for cord blood banking. And I understand that doing them both at the same time is sufficient.
Yeah, definitely. Awesome. Well, I know you said you may not have a story for this, but do you have the impactful story in mind? We can skip it if not.
No, I don't have anyone that I've had.
Okay, that's okay. Okay, awesome. Well, do you have any questions for me around cord blood banking?
Yeah, just so when we do bank the cord blood, let's say, God forbid, a child does need the blood later on in life, is there only a certain amount that can be used or transferred if they need multiple, like let's say for sickle cell anemia, they need multiple transfusions, or they need multiple treatments. Is there a max number that the cord blood can be used for? Or?
Yeah, typically, so we separate it into 5 compartments. So in theory, they could use each compartment for each treatment. And we've actually already had a parent use the stem cells. So in those cases, they did only use 2 compartments at a time, and then they did 2 separate treatments. So yeah, I think it just depends on the physician's discretion and also the age of the child, because their body would be smaller if they're younger. So yeah, it just depends. But yeah, in theory, they could use it multiple times.
Okay, and then I think this blood is kept for 20 years?
Yeah.
What do you guys do after?
Yeah, so they can choose to renew. So technically the property then, or the property of the stem cells becomes the child's.
Okay.
So yeah, it's the child's property after they turn 18. And so from there, they can kind of technically decide what to do, but for the most part, they can extend. And we're actually launching in about 2 weeks our lifetime pricing option. So folks can just pay and not worry about it in the future after the 20-year mark.
And it's monthly.
Yeah, or they can choose to pay 20% upfront and then continue monthly for 4 years or 8 years, and then or they can choose to pay it all upfront. So yeah, it just depends on their sort of financial situation.
Okay.
Cool. From your experience, what advice would you have for expecting parents?
What I see most often is, especially first-time parents, that they're nervous, scared. Of course, the unknown is always scary. Just that, you're not in this alone. That any OBGYN you go with, they're there as a resource to help. We understand it's scary. It's your first time. So utilize us as a resource and try and use us to help make your pregnancy a little easier.
Yeah, that's awesome. Cool. Well, I'd love to move into our twins segment, and I'm super excited because we've actually never had anyone chat specifically about twins. I'm curious what in particular about twins as a topic you're really interested in and why you wanted to sort of speak on it today.
I think twins are fascinating, identical twins, fraternal twins, to, the way that twins develop in the uterus, and the prevalence of twins and how it's gone up, and it being a higher risk pregnancy makes it, more difficult. So it's just something that I've always liked. I've always wanted, something I wanted to talk about.
Awesome. Does having twins always make it a high risk pregnancy?
Yeah, just twins by definition is a high risk pregnancy.
Okay, awesome. Cool. We have some sort of general questions about twins and their prevalency. So first of all, can you have twins if you have no family history of twins?
Yes, you can spontaneously have twins without any family history.
Okay, cool. Who carries the gene for twins? I think from what I understand, it's actually stronger in I think the mom than the dad.
Yeah, so I mean, the simple answer is the mom carries the gene.
Yeah.
So, but for instance, let's say that the father has a family history of twins. To the pregnancy, he won't contribute to twins. But let's say they have a daughter. That daughter has a higher chance of having twins when she has kids.
Oh, okay.
So for that couple, the mom will contribute. But if the father has a family history and they have a daughter, that daughter will have a higher chance of having twins when she gets pregnant.
Why is it that females tend to carry the twin gene?
We're not really sure why, but one of the reasons is because twins develop from two eggs being ovulated, and that's the most common kind of twins. And it's the mom that ovulates.
Right.
So it's the mom that contributes to the risk of twins.
Okay, awesome. How likely is it that a twin will have twins?
There's no exact number on this. I looked it up, but there's no exact number. But the risk is higher for a twin to have twins themselves.
Okay. What in particular makes a parent more likely to have twins? Like I know, for instance, IVF could increase your chances.
Yeah, well, any type of assisted reproductive technology, so like IVF, using Clomid or any kind of ovulation induction. If you have twins in your family, you're considered kind of like a super ovulator, so you may ovulate 2 eggs instead of 1. Demographically, the only risk factor that we've seen in the literature is being of African descent. So some like African American populations in America and anyone in Africa, they have a higher risk of having twins.
Oh, okay. Why is that?
We're not sure, but we just see a higher prevalence of twins in African countries.
Okay.
And the last thing that's kind of low quality evidence is high folate in your diet or taking prenatal vitamin or any vitamins that have a high folate content. But that's a very low quality evidence compared to the other ones.
Okay. What foods are high in folate?
I'll have to look that up, so we have to delete that one.
Okay, sure. I think eggs are high in folate.
Yeah.
So interesting tip. How common are twins naturally?
So naturally, before any of assisted reproductive technology was used, the spontaneous rate of twins was about 1 in 50. And then towards this was in the 1980s. And then towards like the early 2000s, 2010, it jumped to like 1 in every 25.
Oh, wow.
So it went up a lot. And then because twins are naturally a higher risk pregnancy, there was a lot of physicians who didn't want to or felt that they shouldn't expose women to the high risk nature of the pregnancy. So they started only transferring 1 embryo for IVF or not using a higher dose of Clomid or any ovulation induction medication. So the rate went a little bit lower to 1 in every like 30 to 35.
Okay. Are there any other contributing factors to the increasing rate of twin births besides IVF and reproductive technology?
Not that's known in literature, but just those are the main contributors.
Okay.
Oh, actually, and the other thing would be increasing maternal age. So
Oh,
that is
okay.
a risk factor. And because now more women are getting pregnant at an older age, they're at higher risk of having twins.
Oh, interesting. What makes it higher probability that you'll have twins when you're older?
So
are you releasing eggs at a faster rate?
No, the data could be a little bit convoluted because those women are using more assisted reproductive technologies.
Okay. Yeah.
But when they actually had accounted for that as a confounding variable, they saw that the rate was still a little bit higher in older women versus younger women. They're not sure why older women tend to ovulate too, potentially because they're kind of decreasing in the amount that they ovulate because they start having more irregular periods. So when they do ovulate, maybe after 2 months instead of 1 month, they're actually releasing 2 mature follicles instead of 1.
Okay, interesting. How can you have? Well, I guess this is kind of a weird question. Okay, we can take that out. What is the rarest type of twins?
The rarest type of twins, which are the highest risk type of twins, is conjoined twins.
Oh, okay.
Yeah.
Yeah. Have you ever given or assisted with the birth for conjoined twins?
Have I ever done it? No, I've never
Okay.
encountered that.
Interesting.
It's a very rare occurrence.
Yeah. Interesting. What's kind of the craziest study you've read around conjoined twins?
Being conjoined, I think this was in another country, I forgot where, but being conjoined at the head and having to have surgery either right, and actually it was probably after delivery.
Yeah.
I'm not sure if the babies have survived to this date, but I think there was some survival.
Okay. Interesting. Yeah, there was a Grey's Anatomy episode that was kind of along those lines.
I think maybe it was based on a true story then.
Yeah.
With some dramatic effect to it.
Yeah. Derek Shepard, the neurosurgeon, was in on it.
I actually don't even watch Grey's Anatomy, but my sisters watch it and they try and tell me how much they know about medicine. From that, I'm like, all right. I'm like, yeah, so then who's dating who in that show?
Yeah. Okay, awesome. Well, I'd love to move into testing when it comes to twins. So what are sort of the earlier signs that you are pregnant with twins when it comes to any tests that you could potentially run, or when is typically the first indicator that you might be having twins?
So there's no real symptom that tells us whether you're having twins or not. Almost always nowadays with the advent of ultrasound, we just see it on routine ultrasound at their first pregnancy appointment. So usually we see that around the 7-week mark when we could see gestational sacs. And once we see 2 gestational sacs, then we can kind of diagnose twins. One indicator that someone may be having twins is when we take beta HCG, which is the pregnancy hormone, and it's much more elevated than it should be at the gestational age that the mom is at.
I see.
For instance, if they're 4 or 5 weeks by their last menstrual period, and we do an ultrasound and we don't see anything because it's so early, but their beta HCG is really high, then we can start cluing in that there may be twins involved. So that's one. The other potential sign prior to ultrasound is women with twins tend to have more severe nausea and vomiting.
Okay, interesting. Do you tend to test positive sooner with twins for being pregnant because of such elevated beta HCG levels?
No, because the amount needed to test positive is so low that just having twins won't increase the sensitivity of detection.
Okay. So I guess you kind of touched on this already, but how early can twins be detected? Like around what week is that ultrasound typically?
So generally, once you can see a gestational sac and you see 2, so earliest maybe earliest like around 5 weeks, but usually like 6 to 8 weeks once you see those 2 gestational sacs.
Okay, cool. So I know we chatted about twins always being a high risk pregnancy, but what is the highest risk type of twins? I assume maybe conjoined.
Yeah, conjoined twins are the highest risk because they're harder to monitor. You know, when you're doing surveillance for twins, you're weighing both of them and seeing which one weighs more by how much. So when you're trying to weigh conjoined twins or do surveillance, it's really hard to compare when they have some body parts connected.
What causes conjoined twins?
It depends when. We'll have to talk about what causes twins to begin with, but it depends on when the division of the cell happens to cause twins. The later on the division happens, the higher chance of conjoined twins.
Okay. Which twins are the lowest risk?
We call them dichorionic diamniotic twins. But if you want, we can go into how twinning happens so we can understand.
Yeah, for sure.
Okay. So there's identical twins and fraternal twins. In lay terms. In medical terms, it would be dizygotic or monozygotic. Dizygotic is a lot more common, and that's when the mother ovulates 2 eggs. So a mother ovulates 2 eggs, and then 2 sperm fertilize those 2 eggs. And so you have 2 separate embryos from the beginning. They have two separate sacs, 2 separate placentas, and they're always separated. And that's the most common and the least risky set of twins because they have their own living environment. You know, they're not sharing too much real estate and they're not sharing their placenta. So they can get all the resources and nutrients that they need. The other way to have twins is the identical twins would be monozygotic. So one egg gets fertilized by one sperm. And then inside the embryo, the cells are dividing. What happens with twins is instead of the cells dividing, the embryo actually divides, and you get two embryos. And depending on when that division occurs, will dictate whether you have what we call dichorionic, diamniotic, which is two sacs and two placentas. So if it divides early in the pregnancy, around between day 2 and day 4, you're going to have totally separate entities. So two separate sacs and two separate placentas. So those are, again, dichorionic, diamniotic. If they divide between like day 6 or 7 and day 10, you'll have two separate sacs but one placenta. So you'll be amniotic, which means two amniotic sacs, and monochorionic, which means one placenta. That's the second most high risk.
Oh, okay.
And then if they divide in, like after 10 to 13 days, they have it would be monochorionic and monoamniotic, mono, which one sac and one placenta. That's the third highest risk. So mono, and then if they divide any time after that, because parts have already started growing, you have conjoined twins. You have some body parts connected.
I see. So the more placentas, the lower the risk.
Yes. If each baby has its own placenta, the lower the risk. If each baby has its own sac, the lower the risk.
Yeah. Okay. Interesting. Why is twin pregnancy, why does it tend to be harder and higher risk?
It tends to be higher risk because there's any high risk thing that can occur in any pregnancy tends to happen more often in twins. For instance, having preterm labor and preterm delivery. That's actually the most risky thing and most common thing that happens with twins. Hypertension in pregnancy is higher with twins. Gestational diabetes in pregnancy is higher with twins. Having postpartum hemorrhage after delivery is higher. Same with postpartum depression or needing a C-section.
Yeah. So
any complication that can occur in any pregnancy tends to happen more often with twins.
Is it just because of amplified hormones and like just overall amplified like physical affects of it?
Yeah, we're not exactly sure. I mean, the preterm labor and preterm delivery, baby is growing too small, all those and postpartum hemorrhage can be with like the real estate that the uterus has. There's only so much space in there. So if there's two babies, it may be pushing on the cervix more. The two babies they're expanding the uterus. So after delivery, when the uterus is trying to like clamp down and stop the bleeding, it may be a little bit harder. But for the hypertension and diabetes, we think could be potentially from the elevated hormone that's released in the pregnancy.
Okay, interesting. So I know you mentioned morning sickness could definitely be more prevalent when you have twins. I guess like does it happen for longer? What is sort of the difference there?
The length isn't the issue, or even the frequency. It's just the severity.
Oh, okay.
It's hard. The nausea, vomiting tends to be a lot more and just a lot harder to treat. And the reason is because the beta HCG is what causes the nausea, vomiting to begin with. So because twins naturally have a much higher level of beta HCG and it tends to persist for a little bit longer, it's a lot harder to treat, and the severity of the nausea, vomiting tends to be more. But usually by the end of the first trimester, the nausea, vomiting should resolve. Yeah.
Do you have any hacks or tips for morning sickness?
There's a few hacks. I start with lifestyle before I go to medication. This would help actually nausea, vomiting, and acid reflux. That tends to be more with twins too. One, try and eat regularly throughout the day. An empty stomach can worsen the nausea, vomiting because the acid has no buffer with food. So right when you wake up, have crackers by your bedside and just eat something small really quickly when you wake up. Try and eat every 2 to 3 hours, but eat really small meals, and try and eat bland foods like rice or crackers or toast or something easy to digest. Try not to eat any greasy foods. Try not to eat any spicy foods or acidic foods like lemons, lime, orange juice. Those tend to help. And then after you do eat, try not to go to bed or lay down right away. Try and walk around to help with the digestion. And those are pretty much the main tips. And if that doesn't work, then we can try a medication that tends to do the trick.
Okay, cool. Yeah, the Anja Health team actually took a retreat where we went whale watching, and
Cool.
we had a doula with us, and she was feeding us all ginger candies
Yeah,
because she said it helps for morning sickness.
Yeah, actually, I tell my patients if they cook, ginger candies are great, but if you actually buy fresh ginger from the market and just grate it in your foods or your tea or like just eat it with your food, then it definitely helps with morning sickness.
Yeah, that's awesome. Yeah. Our head of operations was getting really seasick whale watching, so she was eating all the ginger candies.
The next whale watching, you have to take me.
Yeah, I will. So what is the most common complication of a twin pregnancy, or even just like general symptom?
So of all the complications that we mentioned, like preterm delivery, hypertension, diabetes, postpartum hemorrhage, needing a C-section, the most common thing is preterm delivery. A lot of it is because women tend to naturally go into labor earlier.
Yeah.
And another reason would be the needing to be induced preterm, depending on what type of twins you have and how or what's going on. Because another risk is babies growing small. And if that is the case, if one baby's growing small or they're both growing small or there's a difference in weight called concordance, then the recommendation would be to deliver earlier. And sometimes early means preterm.
Right.
So whether it's physician induced or naturally spontaneously going to labor, the most common thing is preterm delivery.
Okay. Yeah, that makes sense. One of the most frequently asked questions that we found when looking at twin-related pregnancy questions was, why can't twins go past 38 weeks? So can twins go past 38 weeks, or is it typically not recommended? And what is the course of action?
So twins can go past 38 weeks, but it's technically not recommended because the risk that we're incurring is risk of stillbirth.
Oh, okay.
For di twins, the twins that have 2 sacs and 2 placentas, the risk of a stillbirth after 38 weeks, so after 38 weeks and 6 days, goes up tremendously.
Oh,
and
okay.
The benefit of waiting that extra week to the risk of having a stillbirth, for us, it's not worth it, because babies at 38 weeks tend to do incredibly well.
Yeah.
They don't need NICU admission. They don't need help breathing. They don't have really any problems. So to risk a stillbirth for that added week, to us, it's not generally worth it.
Okay. Another highly searched question was, is twin delivery more painful?
Pain-wise, there's no literature that supports that twin pregnancies are more painful or more uncomfortable. But during the pregnancy, because of the weight that's on the pelvis and the size of the uterus, things that women may encounter is trouble breathing, because it's just the uterus gets so big that it's just not allowing the lungs to fully expand.
Yeah.
And the weight of the babies on the pelvis makes it harder to walk and causes stretching of the ligaments more. So in that sense, there's a lot more pain and discomfort. But the actual labor and delivery process itself, there's no literature to support that the pain scores are higher in those instances.
Okay. Interesting. So I know you mentioned the recommendation tends to be to give birth at 38 weeks, but is there a specific week other than that's the safest week to deliver twins?
Yeah, so it depends. If you're the the least risky twins, 37 to 38 weeks is generally recommended if everything is normal. If one of the babies is growing small, then the recommendations kind of change. Okay. And it has to be very individualized. It depends how small the baby is, the difference in the weights of the two babies. But generally, di twins, the 38-week mark is an okay time to deliver, as long as everything is otherwise low risk. If they're the mono-di twins, then the recommendation is a little bit lower, maybe around like 34 to 36 weeks to deliver, because of the increased risk that entails, because both babies are sharing one placenta. So nutrients tend to flow one way versus the other. If you have the mono twins, meaning one sac and one placenta, complication risks are higher. One being that they're sharing one placenta. The second thing being, because they're sharing one sac, the cords can get tangled with each other or with the baby. So the risk of stillbirth is much higher in the mono twins. So the recommended delivery is around 32 to 34 weeks.
Oh, wow.
Yeah, it goes much earlier when you have mono because the risk of stillbirth jumps up after like 32, 33 weeks.
Right. Okay. So does that also change sort of the recommendation that comes with the type of birth? Like, is a C-section tending to be the option that's recommended for twins, or can folks be pregnant with twins and have a vaginal birth?
Yeah, pregnant women can have twins and have a vaginal birth. It all depends on a few things. One would be the positions of the babies. If they're both head down, then there's same risk as any singleton pregnancy. You just deliver both babies head down. If one of the babies is breech, there's still some room to do a vaginal delivery. For instance, if the first baby is head down, that makes enough room for the second baby, who may be breech, to come out breech. That makes it less risky. However, if the first baby is breech, that's almost in line with just a singleton breech, and not many physicians nowadays are comfortable doing those deliveries because they can resort to a C-section. So most physicians we can take out the dead I know. I think most physicians for breech babies, twin babies where the first one is breech, will tend to do a C-section.
Okay, interesting.
But there is room, and it's doctor preference. Some doctors, if that are willing to do a singleton breech, will be willing to do twin breech also.
Right. Awesome. Well, we have a few Ask an OBGYN questions that tend to be really highly researched questions amongst pregnancy communities. So they aren't about twins per se, but I did want to get your take. So what is the most common question that you get asked by pregnant parents?
I'll do two. One is, when's the earliest I can get an epidural? Like, could I get an epidural in the elevator ride up to my labor and delivery room? The second a lot of it has to do with like prenatals and what they can eat during pregnancy.
Okay. Yeah, one of our questions is, what 4 foods should pregnant parents eat during pregnancy?
As with non-pregnant women, fruits and vegetables always recommended. Balanced diet. Don't remove any food group out of your diet: carbs, fats, proteins. Definitely try and eat some level of protein in your diet because it gives you a lot of the minerals that you wouldn't get otherwise. And then foods that have folic acid, calcium, and things like that.
Okay.
Try not to eat what you should try not to eat. Usually like uncooked foods, like uncooked meat or poultry, or carpaccios, tartares, and things like that. And then soft cheeses like brie, camembert, feta cheese, gorgonzola, blue cheese. You can eat it as long as you make sure it says it's made with pasteurized milk.
Okay. Awesome. What is the earliest that someone can get an epidural?
Technically, they can get an epidural the instant they go into the room, and as early as they want. What they have to understand is, once you get the epidural, it's going to be hard to walk around. So you have to be ready to be laying in bed. If you want to go to the bathroom, you have to be ready to urinate in a bedpan, or even have a Foley place. But the epidural can be left in place for as long as needed, so you can get it as early as you want. But things like if you want to walk around, to the bathroom, it's a lot more difficult,
right,
and even impossible with epidural.
Okay. How much weight will someone gain during pregnancy? What is sort of a healthy weight gain, and even like weight loss in the postpartum period?
Healthy weight gain depends on the pre-pregnancy weight. For women who are normal weight pre-pregnancy, you can estimate about 25 to 35 pounds. And then as their BMI goes up, the amount of weight they can gain goes down. So like, if their BMI is between 25 and 30, you can gain about, 15 to 25 pounds. class 2 BMI would be between 10 and 15 pounds, and anything like morbid obesity, a BMI above 35, it's, you want to gain only about like 10 pounds.
Okay. Awesome. Can you fly while pregnant, and up until what point in pregnancy do you not fly?
Yes, you can definitely fly in pregnancy. Recommendations I would give for flying is get an aisle seat so you can walk around. Especially if you're going far, you want to be able to walk around in the aisle every 2-3 hours. Unless you sit in the window and you don't care to make everyone move, then take an aisle seat. Wear compression stockings because blood clots tend to happen more often in pregnancy, so wear those. That's why you also want to walk around, and also take snacks because these flights they don't bring snacks every 2-3 hours, so you want to be able to eat something every few hours. But you can fly generally I advocate for up until 32 to 34 weeks, as long as your pregnancy is uncomplicated and there's nothing high risk about your pregnancy. Then you could technically fly up until like 32 to 34 weeks.
Okay, awesome. Another commonly asked question is, who will deliver my baby? Is it always the OBGYN, or would it be someone else?
It depends on the OBGYN and the way their practice is run. It could be, if it's a group practice, it could be any OBGYN in the group. If it's a solo practitioner or a private practice like I have, generally I'll be the one to be at the delivery, unless there's obviously an emergency or you deliver right when you get to the hospital. In those cases, there's always an in-house hospital attending to be there for emergencies. So that generally is what happens in those cases. But otherwise, it depends on the structure of the practice.
Okay, so you're kind of around the clock to deliver
your
patients?
Yeah, 24/7.
Okay.
I'm on call.
Wow. The last question that we have is, how long will someone be in labor for?
That also depends. For first-time moms, the length of labor tends to be a lot longer, especially if you're going for an induction. For instance, if you're going for an induction before, if you're just going in for an induction, we're kind of tricking your body to go into labor.
Yeah.
So that kind of takes time. There's actually 2 phases. There's the ripening phase where you're trying to get the cervix ripen, and that, with those techniques, it could take about, up to 24 hours to just get that part started.
Right.
And then we give medication like Pitocin to help the contractions going to get you into more active labor. So, for someone being induced and it's a first-time pregnancy, on the longer end, it can be, sometimes even 2 or 3 days. But again, the first part of it isn't quote unquote labor, it's more of the ripening phase.
Right.
For first-time moms who come into the hospital in spontaneous labor, it depends when they come in. Sometimes they come in 8 or 9 centimeters, and obviously the time of labor is going to be a lot shorter. If they come in 1 or 2 centimeters, or their water breaks and they're still 1 or 2 centimeters, it can take up to about 24 hours for them to deliver. Women who've had multiple pregnancies, with each subsequent pregnancy, it tends to be faster. That's why, you hear people saying, "Oh, I delivered in my car. It was my 4th baby." So, yeah. When it's your 4th baby, once your water breaks, don't go and shower and eat dinner and pack your bags and then come. Try and get to the hospital kind of right away.
Okay, good tip. So do you help parents outside of LA? If someone is outside of LA and listening to this, should they reach out to you for assistance? What is kind of your general location?
Yeah, when you say help them, do I take care of women outside of LA?
Yeah, I guess telehealth, via telehealth.
Yeah, I definitely do telehealth visits. Obviously, if I need an in-person visit after that, we can definitely do that. I also, practice in Torrance, so I do see women that live in the South Bay area, and I operate and deliver definitely through Torrance. Also, I have an Instagram page, so if people have questions, I post videos, I post educational stuff. I'll probably post some of the stuff from here.
Yeah.
If anyone has questions, they can definitely chime in there and ask questions, and
Cool.
those will be answered. So there's different avenues, to get assistance. And there's different ways to, to get in contact with doctors and with me.
Okay, cool. What's your Instagram and other places to be able to find you easily?
Dr. Joseph Roofeh.
Okay, cool.
And then I'm going to start working on a TikTok. That's my next step.
I'm excited for you.
I'm not a millennial or a Gen Z, so I gotta get into that realm.
Yeah, well now you'll be on TikTok with us. With us, you'll be on TikTok.
Yeah, I will. And I'll make my own and.
Okay, cool. I know you have a website as well. What is the URL?
JosephRoofehMD.com.
Okay, cool.
Yeah, and even through there, there's request appointments, there's question appointments. You can use that to ask questions. It comes to my email, and then, I can answer pretty promptly.
Okay, amazing. Well, I really appreciate you being here today. It was really great to chat about multiple pregnancies. Like I said, we've never had anyone chat about that before, but every time I've made content about twin pregnancies, it always does really well, because I think even people that are twins themselves are interested in it, even if they're not currently pregnant. So, it was a good chat.
Yeah, I had a great time here too. And I'm happy I got invited to the whale watching.
Yeah, we'll bring Ginger.
Invited myself.
Yeah.